Female reproductive and maternal newborn care. I am not an OB nurse, but I'm going to do my best. When we talk about contraception, I'm pretty sure we're all familiar with different types of contraception as far as abstinence, withdrawal, aka the pull-out method, calendar rhythm by just tracking the days of the period and trying to determine when ovulation is. Basal body temperature, when a woman especially is trying to become pregnant, this may be something she does. Check her temperature at the same time every day in the morning, your resting basal body temperature. And usually around the time of ovulation, your temperature is going to drop right before and then gradually increase during ovulation. Please bear with me and the toddler in the background. Jamal, cut it out. All right, then we have our barrier methods, of course, condoms, we know about those. Diaphragm. Not many people use a diaphragm in 2021, but I guess back in the 80s and early 90s, these were a hit. It's like a cup. It's reusable. It needs to be refitted every time a woman gains weight or loses more than 20% of her body weight. They need to be refitted. They get a new one every 2 years, and it can be inserted it can be left in as long as 6 hours. So it can be inserted up to 6 hours prior to intercourse. However, this one, just like the IUD, putting a device, especially something like this that you only change every 2 years, if the woman already has a history of toxic shock syndrome, a history of infections, pelvic inflammatory disease, we don't want to be using these forms of contraception. IUD, you don't want to use the IUD with a woman who's had PID before. And I'll go on to talk more about these last few options. Combined oral contraceptives obviously are commonly used. They contain hormones. The problem is those hormones, especially estrogen, places women at extreme risk for thromboembolism, stroke, MI. You need to be very cautious in taking contraceptives, and smoking cigarettes can put you at high risk for blood clot formation. I have seen patients in their 20s who have had strokes from taking birth control pills and smoking. Estrogen also is processed in the liver. So liver disease, gallbladder disease is going to be a contraindication of oral contraceptives. Even people with liver cirrhosis can end up having excessive levels of estrogen. Like men with cirrhosis could get gynecomastia. All right. The other thing about these is, well, of course, these pills do not protect against STDs. They are, like I said, going to put you at risk for stroke, MI, PE. And they do interact with many medications, specifically anticonvulsants, seizure meds. So if you're on seizure meds, the contraceptive may cancel out the seizure med and many other medications. So the doctor really needs to review meds, herbal remedies, all that stuff. IUDs. IUD is the most effective, reliable contraceptive outside of abstinence, of course. It is long acting. You depend on which device you have. You can keep it for anywhere from 3 to 10 years. But like I said before, if the patient has a history of PID or any issues like that, you do not want to put an IUD in there. If that patient it has a high affinity for STDs and you think they're going to probably get pelvic inflammatory disease like you know, someone who's very promiscuous or whatnot, you may want to choose a different method because, of course, having that foreign body in there is just going to put you at a higher risk for bacteria collecting and causing PID. PID, pelvic inflammatory disease, can lead to sepsis and death if not treated. Ovulation. So real quick, ovulation begins 14 days after your first day of your last menstrual period. What's happening with ovulation? The woman's body is getting ready to get pregnant. So vaginal, cervical secretions are going to get thinner. They're going to get less acidic, so the semen can survive and swim up to the eggs. Again, women who are trying to get pregnant, they're gonna be checking their basal body temperature, which cools off initially right before ovulation and then gradually increases. Hyatidiform mole or molar pregnancy. It's a rare tumor. It forms. Stop. Sorry about that. It forms it forms inside the uterus, but what's happening is you just have this overproduction of random tissues that and products of conception that should normally develop, you know, into a regular baby, but it doesn't. So what's going to happen is the woman's going to have a rapidly enlarging uterus. They're probably going to have a positive pregnancy test, just like a regular pregnancy. Stop. Or, and they'll probably have some nausea, vomiting, just like in a pregnancy. It can cause signs of hyperthyroidism. It can cause hypertension and signs of preeclampsia. But the main thing is their belly is going to be growing like a pregnant woman, but rapidly. This tissue is being produced and they're going to have their belly getting bigger. Ectopic pregnancy, however, I talked to you guys about that last week. This is where the implanted ovum, the fertilized egg, is going to secure itself somewhere outside of the uterus where it's supposed to be. Most common place is going to be the fallopian tube, but it can really happen anywhere. Because it occurs usually in the fallopian tube, the sign, hallmark sign, is going to be unilateral cramping pain. Their uterus shouldn't probably be increasing in size because this birth or this baby is growing outside of the uterus. And what happens is, you know, obviously these little small fallopian tubes are not equipped to grow with the baby. So what happens is they can rupture. Like I told you what happened to my sister-in-law. So with that, either if it's early, they will do a medication-induced abortion. And if not, then they'll need to get surgery, depend on the area. So these women, they can have a little bit of spotting, but they likely aren't going to have heavy bleeding. If the ectopic pregnancy ruptures, remember, it's not inside the uterus. So the uterus connects to the cervix and then it comes on down to through the vagina. But if something ruptures up in here, that blood is likely going to just collect into the peritoneal cavity, into your belly. So they may have some light spotting, but they're not going to have active, like bright red bleeding usually. But you could monitor for signs and symptoms of shock like tachycardia, low blood pressure. Again, they're going to have positive pregnancy tests, just like a normal pregnancy. But that baby is not developing in the womb inside the uterus, so they're going to have unilateral pain. All right, now real pregnancy. When we go to talk to the women, we're usually going to ask them about how many times they've been pregnant. That is gravidity or gravida number of total pregnancies, doesn't matter if you made it full term, doesn't matter if you had a miscarriage. How many times have you been pregnant? That's G. So if it's your first pregnancy, you're G1. If it's your second pregnancy, but you had a miscarriage before, then you don't have any parity because you haven't had any deliveries. So this could be G2, P0. Parity is the number of actual deliveries. We use Nagel's rule to estimate the date of delivery. You're going to take the first day of the last menstrual minus 3 months plus 7 days. When we're looking at pregnancy, there are 3 levels to the signs and symptoms. Presumptive signs, obviously, these are things where maybe you could presume you might be pregnant, but many other things could cause these symptoms. Amenorrhea, you could have hypothyroidism or diabetes and have no period. Fatigue, nausea, I mean, you could go eat White Castle and get fatigue and nausea. Urinary frequency, breath changes. Quickening is like feeling like a movement in your belly, like a baby's moving around. I get it all the time when I'm hungry, when I'm nervous, whatever. So that again is just a presumptive sign of pregnancy. Uterine enlargement, we already said the hiatidform, however you say that, molar pregnancy can cause uterine enlargement. Probable signs, okay, we could probably assume that you're pregnant, but still it's not a guarantee. And that would be abdominal enlargement, some changes in the lower uterus and cervix, a positive urine pregnancy test, positive HCG on the blood. Those are all probable signs. But the most positive sign of pregnancy is going to be we actually hear a heartbeat, a fetal heart tone. We actually see a fetus on an ultrasound, and a trained medical provider can actually feel the fetus moving, which your baby will probably be much further along. There are different types of abortion. Even miscarriage is the medical term for miscarriage is spontaneous abortion. Elective abortion is the type where a woman will go to a clinic. You're electing to have it terminated. Then there are different levels. There's threatened abortion, like maybe just some bleeding, inconspicuous bleeding during pregnancy, whatever. There's incomplete abortion, where maybe you've had a miscarriage at home, but there's still some products of conception inside there. That will be the spontaneous abortion. Occurs at home, but maybe now you need help from the doctor, like a DNC, to remove the rest of those products of conception. And then same with inevitable is, we're witnessing it as it's happening. And a woman comes in, she's hemorrhaging, you're seeing you're seeing actually even a baby being delivered, a small underdeveloped fetus, less than 20 weeks, also, and then a missed miscarriage. So some of these, you don't need to, obsess over these different ones. What you need to know is that there are elective, there are spontaneous, which will be a miscarriage, and then therapeutic will be if your baby, if this baby is going to probably, if it's going to be inevitable, if the baby is going to be born with some sort of congenital defect that's likely going to kill them anyways, things like that, then that could be therapeutic. For many of these processes, you would get a DNC. This is going to be dilation of the cervix and removal of those products of conception. What you need to teach your patient is they can resume sexual activity and use of tampons after 2 weeks, okay? Not like with childbirth, it's 6 weeks. With the DNC, it's 2 weeks, okay? Changes to the woman's body in pregnancy. First trimester is when you're gonna start to feel, breast soreness, nausea, vomiting. They're gonna have urinary frequency. As that's the first 12 weeks. as you approach the second trimester, the second 3 months, we're going to see changes in the skin. Those 3 changes, especially more so in darker skinned women, women with olive tone skin, Hispanic, African American, may not be as prominent on Caucasian women, but it happens to all pregnant women. Striae is just stretch marks. Chloasma, I don't know how to say that very well either, is these dark patches. You may notice I have this on my face all the time. And linea nigra is that dark line that forms down a woman's body. These are the 3 skin changes that occur in pregnancy. In the second trimester, a woman may start to see some colostrum, that early breast milk come out, but that urinary frequency goes away. They may have leukorrhea, which is excessive white blood cells in their and vaginal discharge, but it's not infection. And then the third trimester, because that belly has gotten so big, that urinary frequency returns, skin changes continue, and the body starts preparing for birth. When we're monitoring the baby and the mom, well, mostly baby, we do some different tests. Outside of the blood tests, we also do ultrasound, of course. Ultrasound is going to confirm the pregnancy. We're going to be able to see, do you have twins, do you have triplets, octuplets, what do you got going on in there? And we need to make sure there's no congenital anomalies and that the baby has good circulation. That umbilical cord, it should contain 2 arteries and 1 vein. Think about your heart. The arteries carry blood away from the heart. So in this circumstance, the arteries are carrying deoxygenated blood away from the baby to the mom. The arteries are carrying blood away from the baby's heart, but this blood is deoxygenated, just like when the right heart, the right heart pumps blood through our pulmonary artery. It's coming, artery means the blood's coming away from the heart. So the 2 arteries in the umbilical cord are carrying blood away from the baby, and that blood is deoxygenated because it needs to go to the placenta, to the mom's blood, to get some good oxygenated blood. So there's going to be a vein because it's carrying blood back to the heart of the baby. It's a vein, but that vein is carrying oxygenated blood, if that makes sense. Biophysical profile is another exam. It includes the non-stress test, which I'll show you in a second. It includes a non-stress test, and it also evaluates all these things. So doing a biophysical profile can help us figure out any anomalies at birth, all right? Here again, I'm just showing you that circulation. So here's the baby, and that baby's the baby's, wait, what am I doing here? No, here's the baby. I'm tripping. Here's the baby's heart. Here's the placenta. That baby's 2 arteries are carrying blood away from the heart to the placenta, and the 1 vein from the umbilical vein is carrying oxygenated blood back to the baby. It's going to be reverse in the baby, veins and arteries, because we're getting our oxygen from mom. So the arteries carry deoxygenated blood away from the baby to the placenta, and from the placenta, the veins return oxygenated blood to the heart. All right, back to those testing. Non-stress tests. That is going to be used to evaluate fetal well-being as well. They put these monitors on the mom, and they monitor fetal movement and heart rate, right? Normal, a fetus should have some accelerations in the heart rate, which indicates movement. They should have 2 or more accelerations in a 20-minute period. However, you know, just like the rest of us, baby needs sleep too. Jamari, cut it out. Baby needs sleep too. So if it happens to be more than 15 minutes, more than 20 minutes, we don't freak out just yet. It's not considered abnormal until they cannot, we don't see any accelerations or fetal movement in 40 minutes. If that occurs, then we need to get that biophysical profile like I just talked about. Or they may need more invasive stress testing. Now, if the baby's not moving and after, 20 minutes, we may want to offer mom a snack. Most fetuses, they're going to be most active after we increase the blood sugar. So they're going to be more active after meals. So if the baby's not moving, we should offer mom maybe some juice and a snack and see if that helps get the baby in motion with a rush in blood sugar. Amniocentesis, that's this picture here at the bottom. This is an invasive procedure where they're going in with a needle to withdraw amniotic fluid. They do this to detect many genetic disorders, neural tube defects, that kind of stuff. And it can also be used later in pregnancy to determine the lung maturity. I mean, again, mom needs to be very still. And, there's risks, of course, associated with any type of needle or invasive procedure. Mari, stop. Fundal height. So this is one of the things we're checking on mom as well. So at 20 weeks, basically the fundus should be at the umbilicus, the belly button, right? At 20 weeks, halfway through pregnancy, the fundus should be at the top, at the umbilicus. When we're checking the fundus, it's the top of the uterus, right? So if that fundus is below the umbilicus, it's safe to assume that pregnancy is less than 20 weeks. If it's above, then we know it's over 20 weeks. At the umbilicus, you're about 20 weeks. So it slowly grows, with the baby about, and then after birth, you should be at the umbilicus. So halfway through pregnancy, umbilicus, and immediately following birth, umbilicus. If you're slightly above the umbilicus, then you're probably, in between 20 and 30 weeks. If you're just had a baby, we expect you to be here for at least it drops about 1 centimeter or 2 every day. So it's going to take about a week, 10 days to get your fundus back down here. So it's not going to be back. They're still going to look and feel pregnant almost immediately after delivery. Jamari? All right. Breastfeeding after birth does enhance the contraction of the fundus back down to size and help it return back to size. If the woman has to go to the bathroom, a full bladder is going to push the uterus up and to one side. So if you're palpating the fundus and it's up and to the right side or up and to the left side, likely she has a full bladder, okay? Complications during pregnancy include placenta previa. Placenta previa is where the actual placenta, it should be up here at the top of the fundus, but for whatever reason, it gets implanted down here at the bottom of the uterus, and it can partially or completely obstruct the cervix. What the woman's going to experience is painless bleeding, and let me go elsewhere. Painless bleeding, it could be ranging from small amount to excessive bleeding and hemorrhage. So because it's painless, of course, you may not be alarmed, but if that woman is bleeding heavily, it can lead to hemorrhagic shock, right? So usually starts in the second or third trimester. Because this woman is bleeding and at risk for hemorrhage, she still probably is going to need to take it easy, maybe not bed rest, but very light duty. You don't want her exercising. She probably doesn't want to spend hours upon hours at home alone, because if she were to hemorrhage and be alone, she could die alone. You're never closer to death as a young woman until you get pregnant. So a lot of changes going on in the body. Mom is definitely at risk. So placenta previa is not as much of an emergency as abruptio placentae, but it could get to that. Abruptio placentae is where the placenta has detached prior to childbirth. What's happening now is we have internal bleeding and likely hemorrhage. Come on. The most common cause of this is going to be gestational hypertension, but you see here the list of other possibilities. Yes, blunt force trauma, women in a car accident, things like that. Smoking. If you have had this happen before, if your previous pregnancy ended with abruptio placentae, then you're at risk for it happening again. What happens, signs and symptoms, is the uterus is going to be rigid, and that blood, but especially as more bleeding occurs in the belly, that belly's going to get firm. They're going to have severe abdominal pain and likely heavy bleeding. This can lead to shock. It can lead to complications of shock like DIC, because your body is bleeding excessively and your body always wants to maintain homeostasis. So you're going to start producing these clotting factors, trying to stop the bleeding. And these women can end up with DIC and die. Those women also need to be on bed rest. They should not be moving around at all, okay? Bed rest. Gestational hypertension. This begins now, it can be benign or it can cause serious complications. If you just have regular gestational hypertension, that starts usually around the 20th week of pregnancy, but it does not cause any kidney damage. This just means a woman's blood pressure is greater than 140/90, and her blood pressure should go back to normal within 6 weeks postpartum. So by that follow-up visit, if it's just gestational hypertension, it should go away once they go back to the doctor for their follow-up visit. However, if it persists and starts to cause issues in the kidneys, and the woman presents with high blood pressure, but now she has proteinuria. See, on every prenatal visit, the doctor is collecting urine. It's not to do a pregnancy test. It's mostly to check for protein in the urine. We don't even care about UTIs like that. We're looking for protein in the urine because preeclampsia can progress to eclampsia, progressing to seizures, could kill both mom and the baby. So mild preeclampsia is the same as gestational, except you have small amount of proteinuria. Severe preeclampsia is going to progress. They're going to have large amounts of protein in the urine. They may start having signs and symptoms of kidney failure like oliguria. You're going to have elevated creatinines. They may start to have headache, blurred vision, hyperreflexia. Severe preeclampsia can lead to that HELP syndrome, which I'm going to talk about in a second. They are going to have extensive edema, and they may start to have heart issues, pulmonary edema, that kind of stuff. Severe preeclampsia, again, these people are likely going to be on bed rest. We do not want them to progress to eclampsia. Eclampsia is going to be all of this I just mentioned, plus seizures. Seizure activity, usually women have an aura like other people with seizure disorders. The aura could be a severe headache with blurred vision, or it could be a sudden onset of sharp abdominal pain, but this is eclampsia. HELP syndrome means hemolysis, breakdown of red blood cells, leading to jaundice and anemia. I hope you guys remember from med-surg, red blood cells, when they die, hemolysis, that's dying of the red blood cells. When they die, they release bilirubin. Bilirubin is yellow in color, and it is processed out by the liver, and it's turned into bile. And then the bile is used, it is excreted in the bowels, and it's used to break down fat in our diet, right? So when a patient has hemolysis, whether it's HELP syndrome, whether it is our newborn babies who have that RHO incompatibility and they have hemolysis. When a person has hemolysis, they could develop jaundice, right? Because it's excessive bilirubin buildup and the liver has to work with that. So because of that excessive bilirubin buildup, we're going to increase the workload of the liver, and they're going to have elevated ALT and AST. These are your liver enzymes, ALT, AST. You need to know this. You need to know that for NCLEX. You need to know about the relationship between bilirubin and the liver and bile, because if you know all these things, I'm telling you, it will help you. You need to know how the body functions. So because of that ALT, elevated AST, they also end up with the liver failing. Now they end up with low platelets. Low platelets, also known as thrombocytopenia. Again, this is going to increase their risk for bleeding and DIC. Whenever a person has excessive hemorrhage, bleeding, what happens, it kicks off the body's response to create clotting factors, right? If your body is trying to compensate and keeps producing clotting factors, eventually that's going to run out. And that's how those people get DIC. They go from excessive clotting to excessive bleeding. Remember that from weeks 1 and 2. Nursing consideration. So for any of your patients who've got preeclampsia, eclampsia, risk factors are listed right here on the left. You see first pregnancy, chronic hypertension, of course, is your highest risk. Family history, molar pregnancy. You can get the development of all these issues and not be pregnant with a real baby. You can have that molar pregnancy. Remember how I said that RH incompatibility is going to lead to hemolysis. Hemolysis is going to increase the workload of the liver. That leads to HELP syndrome too. So things you need to do: 1, low sodium diet. We could do a fluid restriction, but we got to be careful about that because this is a pregnant woman. We need to monitor blood pressure very closely. Just like any pregnant woman, you shouldn't be smoking and drinking in the first place. Treatment for this, nifedipine, is one of those tocolytic drugs that will hopefully not only lower, it's a calcium channel blocker, it will lower blood pressure, but it should also hopefully prevent the progression to eclampsia and early uterine contractions, premature delivery. So, and we'll talk about tocolytic drugs in a minute. Mag sulfate, you need to know about this. We give magnesium sulfate to prevent seizures. Remember, hypermagnesemia leads to excessive muscle weakness. We are giving the magnesium to relax the muscles, relax that stimulation, and prevent seizures, prevent early uterine contractions. In patients in acute respiratory distress, we may give them IV magnesium to relax the bronchial muscles. So we're giving the drugs to relax everything, but if we give too much, the person could go into respiratory depression, and their muscles become too weak. They're not able to use those muscles to breathe, and they could die. That is hypermagnesemia, remember from med-surg. So you need to watch your pregnant ladies receiving mag sulfate for signs of respiratory depression. The antidote for mag is calcium gluconate. All right, some developmental disorders. Spina bifida. Spina bifida is basically the spinal bones, the vertebrae are unable to close. They don't close properly. And now we have a sac form. This is the baby. So this is the baby's butt, right? This is her, his or her diaper. This is the back here. This is that neural tube defect. This is a neural tube defect. Your spinal cord is your neural tube. There's a defect there, and now we have either just cerebrospinal fluid, but more commonly, it's going to be nerves and cerebrospinal fluid in this sac. If a baby is born with this, it is our duty to maintain the integrity of this sac, because if this were to rupture or become infected, that's going straight to the nervous system, into the spinal cord. We need to protect and maintain the integrity of this sac. Furthermore, to prevent spina bifida, folic acid, folic acid is what women need. This is why most of our cereals and foods in America are fortified. Fortifying our cereals has reduced significantly the risk for neural tube defects in infants and newborn babies, because in America, most of our food is fortified. So folic acid, that's what's in our prenatal vitamins as well. Usually, even if a woman, an American woman, is eating an American diet, likely this should not occur. But you want to encourage an increase in iron and folic acid for mom to prevent neural tube defect. All right, so now mom's going into labor, false labor versus true labor. Now you can have Braxton Hicks, which are just, they're like fake contractions, usually occur with dehydration. So Braxton Hicks contractions are false labor. They can usually go away with walking and drinking water. Like I said, they're usually brought on by dehydration causes muscle cramps, right? What's happening with contractions? It is cramping, the muscle is contracted. So dehydration usually is what leads to Braxton Hicks contractions. Whereas in true labor, those contractions are becoming regularly, they're coming in regular intervals, they're increasing in intensity, and they don't change regardless of you drinking water. And usually intensity gets worse with walking. Cervical effacement is not going to occur in false labor. True labor is when the cervix becomes thin, effacement, it starts thinning out like this because the baby's head is dropping. And dilation, it starts opening up. It's thinning out and it's opening up, okay? And you see it here too, right? That's going to be true labor. Bloody show, not present with false labor, but it's going to present, the membranes rupture and you have bloody show with true labor. And then of course you shouldn't be seeing the baby's head or anything when there's no true labor going on. Now, this is a pediatric, this is from one of my classes, one of my lectures in med-surg. But this is basically the pediatric immunization schedule. The way I remember what you can give a mom is if it can be given to an infant or a newborn baby, then it's probably safe for pregnancy. If I have to wait a year before the baby could get it, like a varicella or an MMR, then I probably cannot give it to a pregnant woman. What I can give a pregnant woman, I can give her an inactivated flu shot, but I can never give a pregnant woman anything active. So no varicella, no MMR, and no active flu shots for mom. Mom can get a Tdap because DTaP is for babies, but Tdap is the adult version, and she can get an inactive flu vaccine if need be. But no varicella, no MMR, and no active flu vaccine. When you're applying fetal monitoring and you're watching the baby, baseline fetal heart rate should be between 110 and 160, right? You're going to do it on admission for these women, even if they're coming in and it's not a true labor. You're going to do it during amniocentesis, any types of procedure, any medication that's going to affect the baby. I mean, it's just like applying a heart monitor on an adult. I mean, it's a monitor to watch the baby. There's many reasons why you would apply it. Now, I got this straight out of ATI. When you're looking at heart ranges, fetal heart rate changes, the accelerations, decelerations, then there's this acronym, VEAL-CHOP. So if you have variable decelerations, it's likely due to umbilical cord compression. Early accelerations is going to be head compression. Think about it, the head is getting squeezed out. So that can probably cause pain in the baby. So early acceleration is going to be a sign that, that head is moving and it's being compressed. But if it's compressed too long, then we could end up with some birth defects. Acceleration is okay, it's fine, that's what we want to see. And late acceleration could mean placental insufficiency. We don't have good circulation going to the baby, or ureteroplacental insufficiency. So you need to know the difference between these. So I think if you remember this VEAL-CHOP, it should help you. All right, so if a woman is having early pregnancy, early labor, we may give her tocolytic agents to stop the labor. Here's something I found online to help you remember the drugs. Here's a mnemonic, it's not my time. Indomethacin, nifedipine, like I told you about, mag sulfate, and terbutaline. Those are all drugs that could stop uterine contractions. Now, after 36 weeks, it's okay for the woman is full term, go ahead and deliver. It is contraindicated in women over 6 weeks gestation. Also, a pregnancy under 20 weeks is not a viable pregnancy. So typically it's not given unless, we don't want to stop contractions either when the pregnancy is not going to, even if the baby's born, it's not going to make it, or if the baby is old enough and mature enough to just be born. So it's contraindicated after 36 weeks gestation, but we will give it to women like, 25, 30 weeks, whatever, who are going into labor. They do not stimulate labor. They are administered to stop the labor. These drugs here. All right. Umbilical cord compression. Like we said, you'll see variable decelerations on the fetal heart monitor. If I suspect compression, I just spelled that wrong, but compression, then we need to be worried about that. We need to do an exam. If I see umbilical cord prolapse, so you see this cord is coming out to the vagina, then I need to put on a sterile glove and actually insert 2 fingers and relieve the pressure. This is cutting off blood flow to the baby. Baby can end up with an anoxic brain injury. Baby could die, okay? You gotta do what you gotta do. So we're gonna take a sterile glove. Well, of course, at the same time, call 911. 911 means call a doctor, call a team, because we are getting ready for an emergent delivery. That cord cannot be compressed like that, and you cannot live your whole life with your 2 fingers in the woman's vagina. So you're gonna insert 2 fingers to relieve oxygen. You're gonna apply high flow, to relieve pressure. You're going to apply high flow oxygen to deliver as much oxygen as possible to the baby. You may reposition the mom with the knees to chest in a fetal position. And if that cord is all the way out of the body, then you need to wrap it in some sterile moist gauze. But number one priority is to restore circulation to the baby. So that's going to be inserting your fingers and relieving that compression. Amniotomy. Amniotomy is when they break the water bag or rupture your amniotic membranes for you. They did this for me when I was delivering my son. I was in labor for literally 36 hours. I was just constant contractions, but nothing was happening. They may use something that looks like a crochet hook, or they may use this special glove that's got a little needle type deal at the tip. Either way, it's to rupture the fluids, right? So when they go in and they rupture your amniotic membrane, it's going to increase the contractions. It's going to cause labor to progress. You're going to monitor frequently for fetal distress. Most important, everything, ABCs, okay, guys, ABCs. You need to monitor for fetal distress, monitor fetal heart rate first and foremost. You also need to just assess the color and consistency of the fluid because there's meconium, which is like that first bowel movement. If meconium fluid is in the amniotic sac, the baby has had a bowel movement in utero, that's going to put them at high risk for pneumonia and other sepsis. So you want to observe the, color and consistency and monitor temperature. A woman getting this done is at high risk. Her and the baby are at risk for infection. So monitoring temperature. Postpartum, again, like I said, the fundus should be midline and at the umbilicus. It should be at the umbilicus immediately following birth. It takes about a week or so for it to get down to the pelvic region. So at the umbilicus is where the fundus should be immediately following birth, and it should drop maybe a centimeter or a finger breadth per day, okay? If it is soft, if it is boggy, that could place my patient, that's going to put my patient at huge risk for hemorrhage. So fundal massage, you need to massage the fundus. They are going to have discharge for a couple weeks, maybe even up to 6 weeks. Initially, they're going to have lochia rubra, that is a red bloody discharge, may come with clots, okay? That is normal for 1 to 3 days. Normal, 1 to 3 days. Not products of conception, but maybe what looks like clots, okay? And then after 3 or 4 days, it's going to start to lighten up and get pink. And after about 7 to 10 days, it may be a whitish color, maybe an off-white. And that can last several weeks. You're going to assess the perineum, looking out for this, redness, edema, ecchymosis, drainage, and approximation, meaning are the 2 edges well approximated? Or is there a tear or something? Did she have an episiotomy where they had to actually cut, make a cut to make room for that baby's big head? Assess for bladder distension. Bladder distension can put the patient at risk for uterine bleeding. We need to assist mom to void frequently to decrease her risk for bleeding. Assist with urination. You may even need to perform bladder scans. Again, uterine atony, that is that soft, boggy uterus. That can happen, especially if you had a big baby. Macrosomia, those big 10, 11-pound babies are going to put you, that's going to stretch you out and have a loose, boggy uterus. If you've had 4 or 5 babies in your uterus all at once, you know, twins, triplets, whatever, that's going to put you at risk. Prolonged labor. use of mag sulfate, because that's relaxed your muscles so much. And then actually an oxytocin induced labor can also put you at risk. Signs are going to be, she has saturated one pad in less than 15 minutes. It's taking, now you will initially have some bleeding, but if you're saturating one pad in less than 15 minutes, and if you're having large amounts of blood, greater than 500 mL, less or greater than 1,000 in a C-section, then we want to first and foremost massage the fundus. Of course, provide oxygen if needed. These are drugs, again, the tocolytic drugs are the ones you're going to use. I'm sorry, not tocolytic drugs. These are drugs that are going to enhance contraction of the uterus. So oxytocin, methylargonabine, misoprostol, those are going to be given to women with boggy uterus. You want to be watching out. Make sure they don't go into shock. They're going to need O2, monitor vital signs. If they're showing signs of shock, they need IV fluids. We need to replace that fluid, okay? Start an IV. Now to the newborn. We're going to assess the newborn. ABCs, of course, airway, breathing, circulation. They suction that mouth out. Of course, M before N in the alphabet, LMNOP, right? Mouth before nose. Don't be suctioning the nose and then the mouth. We don't put boogers in the baby's nose. In the baby's mouth, okay? After you got the airway, breathing, and circulation figured out, thermoregulation is your next priority. Keeping that baby warm and dry. Hypothermia can cause increased oxygen consumption, can lead to hypoglycemia, and just poor outcomes for the baby. They cannot regulate their body temperature. It is critical you dry them off, wrap them up. You may give them to mom for mom to hold skin-to-skin contact, called kangaroo care, breastfeeding, to keep the baby warm. Hypothermia needs to be prevented in babies. And then I just put this here. This is the APGAR score. It's going to get assessed at 1 and 5 minutes. The normal score should be 7 to 10. If it's falling less than this, then we know we have fetal distress. Again, this is just looking at your baby, looking at your infant, things you're going to do after birth, meds to be administered, yada, yada, how to help them breathe. These are your newborn reflexes. You need to know these. Rooting is where I tickle the side of your cheek and they start sucking. Palmar grasp. If I put my finger in the baby's palm, she's going to grasp it, right? Babinski, I'm going to stroke the bottom of your foot, and I expect your toes to fan out, okay? And then the startle reflex or the moral, you may clap your hands loudly by the baby and see that they make that startling motion. Tonic neck reflex, you're going to turn the baby's head and see their legs curl up, okay? Into this one arm is going to go out with the way the head's turned up. So again, you need to be familiar with your reflexes. These are all normal at birth. If a baby is premature, they may not have, they may be missing some of these reflexes. If a baby is post-mature, meaning they were born beyond 42 weeks, all the reflexes should be present, okay? And going on to talk about gestational age, this is, we look up new, you need to be familiar with the new Ballard score. New Ballard score. It includes those, the fine motor or gross motor, sorry, of the baby and physical maturity. So if our baby is post-mature, born after 42 weeks, they may have cracked, leathery skin. Their fingernails may be thicker and harder. They look older than those babies. So you need to look up New Ballard score and looking at maturity. Now, that umbilicus, we're going to cut the umbilical cord and end up with this little weird looking stump, right? Mom is going to be taught to keep that stump clean and dry. You don't need to really wash the cord rigorously. You just wash around the base of the cord with soap and water. You don't need a bandage on it or any of that. You want the cord open to air so it can dry out and fall off like it's doing in the picture. Don't cover it with the diaper because you're going to put them at risk for urine and stool getting on there and infection. You don't need to apply moisturizers. Moisturizers, you could apply petroleum jelly to a baby who's had a circumcision to the penis, but not to the umbilical cord. We want it to get dried out and fall off, okay? Medications you're going to give the baby prior to discharge. Hep B, we know that's the first vaccine. They get it at birth, 2 and 4 months, like I showed you before. Every baby is going to get an antibiotic ointment, maybe a tetracycline like erythromycin ointment to the eye. That would prevent any blindness if mom were to have a STD at the time of birth. We give up to every baby though. And then vitamin K injection, because they have that immature liver and everything, they need clotting factors. So these are the 3 meds that the baby's going to get prior to discharge. This was just another thing I found on the internet to help you remember, you know, your newborn assessment. You got the APGAR score, you got the, you know, monitoring for temperature loss, how to prevent hypothermia, umbilical cord, remember 2 arteries, 1 vein, yada, yada, yada. And I'm going to talk about this caput succedaneum, okay? Caput succedaneum. This occurs, I actually put a great video in here. It's 5 minutes of a guy talking about the difference between caput succedaneum and cephalohematoma. So caput succedaneum is like edema in the soft tissues, very common, happens after birth with the molding. As the baby's head is getting squeezed out, you know, some fluid collection, they get this weird shaped head. The difference between the two, this is a collection of blood. This is not. This is just edema, and it goes down within a couple days. It also, this is in the subcutaneous tissue, so it can actually go across the suture lines of the skull, whereas this bleeding is in the layers of the skull, and it does not cross the suture lines. It stays on one side. Usually both of them will go away. This one is way more common. It definitely, you're going to be at higher risk of this when using a vacuum assisted delivery. You want more? You have a bottle right here. Good job. Vacuum assisted delivery is going to put the baby at even higher risk of this caput succedaneum. There's nothing to do about it. I mean, most babies are born with a weird shaped head. It'll just go away. However, this hematoma could take several weeks to go away, but it shouldn't usually cause the baby any problems. I'm emailing you guys the PowerPoint, but here is a video on this slide about the difference between those two. And yeah, here we go. All right. So hopefully that helps you distinguish between the two. Hold on. Now let me move on. Oops, sorry. All right. Almost done. About 3 more slides. Okay. Breastfeeding. So, I mean, a mom's going to choose whether they want to do breastfeeding or formula feeding. That's personal preference. Breastfeeding, those babies do typically lose a little bit of body weight before gaining weight. When colostrum, that is our first little bit of, pre-breast milk. It's very rich in nutrients and antibodies, and that's all they're going to get for the first 2 to 3 days is colostrum before real breast milk begins to develop. That's around days 3 to 5. However, it takes about 10 days before that milk all the way matures, but real breast milk will occur in 3 to 5 days. So because the milk is not fully mature. That could be a reason that the baby, loses weight. It could be due to inadequate feeding times. If mom is not leaving the baby on the breast long enough or offering feeding frequently enough. But either way, if you're a mom and your job is to make the food in your body and provide it to a baby, you got to be careful how you approach this. You don't want to offend anyone. These moms need a lot of encouragement and education, especially if you're a new mom. So alternate breasts. If baby cannot drain both breasts, then they need to pump the other breast. Like if the baby gets full after one breast, pump the other side, because you do not want engorgement. Engorgement can be very painful. And the way you could get rid of engorgement would be to pump or have baby feed. There is such thing as a letdown reflex. The letdown reflex, any stimulation of the mother's nipples could actually release oxytocin, causing milk to just come down, or uterine contractions. But most moms will tell you, breastfeeding moms, even sometimes when the baby is hungry and starts crying, it'll happen. It happens in the shower. It can happen. So if a mom brings a baby in and they're concerned about weight loss, you need to just talk to them about their feeding techniques. All right, couple drugs you'll need to know. Methylargonovine, that drug is the one I told you. It's used to promote uterine contraction. We give it for treatment of postpartum hemorrhages. Of course, because of this contracting, it also increases blood pressure. It is contraindicated in those with hypertension. So know that. Methylargonovine is going to help contract and firm up the uterus, but it is a high-risk drug to be given to someone with hypertension. Dinoprostone gel can be applied to the cervix. It's also known as Cervidil. It is a gel applied to the cervix, either with a suppository of some sort. It is used to soften up or ripen the cervix, and it may also stimulate uterine contractions. It's to get the body ready for labor. One last complication, and then I'm done, with newborn babies, is jaundice. Like I said, when red blood cells die, we are left with bilirubin. Bilirubin is yellow in color, and it is processed out the body. It's a waste product that is filtered out through the liver. So there are two types of jaundice. Physiologic, which can occur after a few days of birth, after 24 hours or more, it develops. So that usually is benign, and it's probably just because the baby just has a little, when the baby's born, we have that fetal cord, they have all this stuff going, the umbilical cord and all these fetal cells that they may not need anymore now that they're born. So of course, some cells are going to die. Our cells, we are replacing red blood cells every day of our life, okay? But physiologic jaundice is thought to be due to just you have an immature liver. Again, they're not born with that jaundice. It usually occurs after a day or so. Versus pathologic jaundice is the one we're concerned about. And that is when they're born yellow like this. They're born jaundice because they have this buildup of bilirubin. Why? Because they have had excessive hemolysis, hemolytic disease, usually due to an RH or ABO compatibility. Mom's body has tried to attack that baby in uterus, and so they've had a large amount of cells dying much faster than the liver can handle, leading to excessive bilirubin, which is going to cause jaundice. The reason we are worried about this is because bilirubin could cross the blood-brain barrier, causing kernicterus, which is irreversible brain damage. So when a baby's born with jaundice, we are concerned about this Rh-ABO incompatibility. And we're concerned because this bilirubin excess can lead to kernicterus, which is irreversible brain damage. Here is your risk factors here, but like I said, the biggest one is being concerned about this incompatibility. The Coombs test is the test we do. I'll talk about that in a second. Actually, let me go to that and then I'll come back to this slide. The Coombs test, right? That is checking for that RHO compatibility. It's checking to see if mom's body, what happens with this incompatibility is mom is born with negative blood. For me, I have B negative blood. Prior around 28 weeks gestation, we're going to check mom's blood type. If it is negative, then we are going to give her RhoGAM or RHO immunoglobulin, okay? It's given at 28 weeks gestation. And if we don't know the mom's outcome, then we're still going to give it to them after birth. Either way, the RhoGAM is administered to prevent mom from creating those antibodies. Just like in our immune system, when we recognize, say, a virus of some sort, COVID, right? We start making antibodies to attack it. If the baby has B positive blood and mom has B negative, those negative antibodies, they're going to create antibodies to attack the baby. So that is the purpose of that. When mom has been attacking the baby in utero, then all those, we see multiple blood cells dying at one time, and that's how bilirubin builds up and the baby gets jaundice, remember. So that's hyperbilirubinemia. That is that jaundice in the baby. Treatment for this is going to be phototherapy. Phototherapy. So phototherapy is like laying a baby in a tanning bed, right? When a woman goes to the tanning salon, even if you've never been, I'm sure you've seen on TV, they put those little glasses, goggles on. We got to protect the eyes, protect the cornea and retinas. We're going to monitor skin integrity, make sure, they don't have skin breakdown because they need to be laying under that phototherapy lamp all hours of the day. We will monitor for dehydration. Of course, babies cannot control their insensible water loss. So we do need to make sure they are hydrated. We need to monitor blood or body temperature frequently. And we are going to, of course, take them off the phototherapy to allow feeding, of course. So feeding, again, like I said, think about it. Bilirubin builds up in the body. It's filtered out through the liver. It is turned into bile, and that bile is sent to the intestines to emulsify fats and break down food, right? So early feeding of the baby, this is why we feed babies early as well. It is going to increase bilirubin excretion in the bile if we're putting more food in the intestines. So that also is going to help us get rid of the bilirubin. And that's that. So hopefully you found this helpful, and good luck on your exam.